Hello, everyone. Welcome to our Facebook Live Ask an Expert with TGH. This is part of our live Q&A series on lung cancer screening and treatment options. And of course, this is all a part of a culmination of Lung Cancer Awareness Month, which is the month of November. My name is Phil Buck. I'm the Public Relations Manager here at Tampa General Hospital. I'll moderate today's conversation. And I do want to start with a big announcement because we are thrilled to share that last week, Tampa General Hospital's Cancer Institute received national accreditation from the Commission on Cancer, a quality program on the American College of Surgeons. So, this is a significant achievement. It really underscores the exceptional, groundbreaking work that's being done here at Tampa General Hospital, along with USF Health and our private practice physicians. So this is an exceptionally rigorous process. I would love for you to please join us in congratulating the entire team on this impressive act. Of the guests today are some of the in the areas of lung cancer and screening here in the Tampa Bay area. We are so excited to have them with us here today. Thank you so much for your time. Please welcome Dr. Jonathan Daniel, thoracic surgeon, TGH Cancer Institute, Dr. Noman Ashraf, Associate Professor of Medicine in the Department of Hematology-Oncology at University of South Florida, and Jenny Martínez, a lung cancer screening navigator here at Tampa General Hospital. Thank you all for being with us today. A little housekeeping before we get into the discussion. This is a live Q&A session, so I do want to encourage audience participation. If you have questions during this live session, please go ahead and place them in the comment section. We'll try and get to them. However, I do want to say we already have had a lot of great questions pre-submitted, so that tells us that this is a hot topic that's important to a lot of people on today's discussion. So thank you for being here. And finally, please try to keep your questions as general as possible so that they apply to the broad audience. Of course, we're talking with our medical experts here today, but always for individualized medical advice, it's very important that you always consult your primary care provider. But I would love to get into this conversation here with our subject matter experts. We will start with just some facts. Lung cancer is the leading cause of cancer more than any other type of cancer among men and women, but there are ways to find this cancer in its earliest stages while it's still treatable. So let's start with Dr. Noman Ashraf, maybe by getting to some of those pre-submitted questions. I want to clarify, we edited some of these for clarity and to keep them as general as possible, but we got a similar question from both Maddie and Chazelle, who asked, what are the symptoms of lung cancer? And are there any symptoms that mask themselves to not suspect having lung cancer? Dr. Ashraf?
Yes, thank you for having me here today. Absolutely, excellent question. Lung cancer can have symptoms or not have symptoms, and that's an important distinction. So in the early stages, lung cancer may be asymptomatic, and that's why we're pushing for screening, as you mentioned. Early stage lung cancer can be cured, and we want to pick it up at that stage. But if you have symptoms, things to look out for are coughing, coughing up blood, becoming short of breath, particularly on exertion, unintentional weight loss, or chest pain. Again, if lung cancer spreads to other organs like the bones, the spine, the brain, then it can cause other kinds of symptoms like headaches or bone pain, back pain, something like that. But again, the important thing to remember is that a lot of times patients with lung cancer in the beginning will not have any symptoms. It's usually when it's more advanced that patients will start having symptoms. I hope that answers your question.
Questions. So, thank you very much, Dr. Ashraf. Let's go over maybe to Dr. Daniel. David wanted to know, is there a cutoff age for a lung transplant, even if other organs are in reasonable shape? And it follows up with, does O2 level need to be at a certain level to be on the transplant? Dr. Daniel?
That's a great question we get often. There is something called the lung allocation score that actually will determine your ranking and eligibility for a lung transplant. There is not an actual oxygen number that we expect. The real key is what your oxygen level is when you're on room air. So you're actually not on oxygen, and how low does that drop? So it is correlative with how much oxygen you need on a daily basis. But that is a frequent question that we have, but a lot goes into determining someone's eligibility for lung transplant. Since this is a discussion of cancer, one of the questions we often get is, can I get a lung transplant if I have lung cancer? Unfortunately, for most patients, because of the aggressive nature of lung cancer and the need for immunosuppression with lung transplant is not a conventional treatment. However, there are a new class of patients with a very low-grade type of lung cancer. It's called minimally invasive adenocarcinoma. And there are some areas where we are experimenting with lung transplant for those specific types of patients. But an excellent question. Thank you.
Add those in the comment section, and we will try to get those to our experts as quickly as possible before we wrap up today. Another question may be, what happens? Maybe I'm not a smoker, but I was around smoking, secondhand smoke. Can I still get a screening? Maybe Jenny, do you want to take that one?
So unfortunately, with the guidelines right now, it's specific to a current smoker or former smoker who is considered a heavy smoker who quit in the last 15 years. And the age group is between 50 and 80. But if that isn't concern, I always recommend for a patient to have a discussion with their doctor and see if their physician feels that they need to have a screening.
Excellent. Thank you. Here's another one for you, and maybe Jenny, you want to take this. Janice asked another really fantastic pre-submitted question. I'm a former smoker with a pulmonary nodule, and recent CT shows asbestos exposure. Should I be screened for lung cancer?
I think this would actually be a better question for like Dr. Ashraf.
Absolutely. So irrespective of the asbestos exposure, if this was a former smoker and quit within the last 15 years, I would definitely recommend lung cancer screening. Now, asbestos, you mentioned, obviously does increase the risk, and the combination of smoking and asbestos exposure exponentially increases the risk of lung cancer. We hear about mesothelioma, which is actually a cancer of the lining around the lung, but also it not only increases the asbestos, increases the risk of mesothelioma, but also increases the risk of developing lung cancer, even more so than of mesothelioma.
Good. Again, I'm just going to keep them coming. You guys are doing a great job fielding these. Carol submitted a question. This is insurance related. Wanted to know, is this covered by insurance like Medicare, the screening in particular?
I can take this one, yes. So for most major health insurances, this is considered preventative health or preventative care. So it is covered for the screening.
It's good to know. Again, I want to remind our audience, if you have questions, please submit them in the chat. A lot of folks, as we mentioned, submitted them ahead of time, so we'll keep getting to those. Dawn wanted to know, she said, I had lung cancer, had surgery, and now do a follow-up every 6 months with a CT scan. Should I be doing anything else?
I can take this one. So I think you're doing the appropriate thing. Obviously, surveillance after treatment for lung cancer survivors depends on the stage of lung cancer. In the beginning, first 2 years, 2 to 3 years, I should say, we scan patients more frequently, and then we decrease the frequency and sometimes go to once a year after that. Obviously, the most important thing is to prevent any risk factors. So if you were smoking, then quitting smoking is the most important thing for you to do. But as far as lung cancer surveillance, you're on the appropriate lung cancer surveillance. CT scans are the best test. Obviously, if there's any change, that would usually require a biopsy or sometimes a PET scan. But yes, that is, according to the guidelines, the appropriate screening for surveillance, sorry.
Excellent. I do like to pause just to give Dr. Daniel or Jenny a chance to hop in if they have anything to add.
No, certainly. Just extending on risk factors. What do you tell patients, Dr. Ashraf, when they ask you if it's relevant if they have family members who've had lung cancer, and should that affect either their screening or the way that they manage potential disease?
Yeah, that's an excellent question. So at this time, we don't have any formal guidelines to recommend, like if you have a family history. If they have a very strong family history, I do recommend referral to our genetics clinic. We here at TGH have a genetics clinic, and they do a more detailed assessment, and we can test them for germline mutations, which means that if they're born with some genetic defects that increase their risk of developing different kinds of cancers. So that's usually what I recommend my patients. Now, sometimes we do see certain types of lung cancer which can run in the family. And in those patients, I'm even more inclined to send them to our genetics clinic for a more detailed discussion.
Good conversation around that. That's an excellent point you bring up there. And this next question, actually, that was pre-submitted, is somewhat related to family history. I mean, not directly, but Alexandra mentions that my mother was diagnosed with stage 4 lung cancer that metastasized rather quickly. She wants to know what's being done for early detection, which is related to what some of you discussed at the top.
Yeah, absolutely. So Jenny mentioned the low-dose CT scan, which is being used to screen asymptomatic. That means that people who do not have any symptoms, who have a history of smoking or are current smokers. So that's currently the standard of care. There are other things that are being tested at this time as well. There are studies going on looking at blood tests to look for circulating tumor DNA in the blood, and that might be something that we might have in the future. There are other tests like doing nasal swabs for patients, and that's just taking a sample, just like, for example, like the COVID test, they were doing similar to that, and that may change how we screen patients. Again, whenever we talk about any sort of a screening program, you have to weigh the risks versus the benefits. So it's not worthwhile screening 20-year-olds with these tests, but usually it's the people who are at increased risk, whether it's from smoking or a very strong family history. So those are our current areas, but at this time, the low-dose CT scan is the preferred method of screening and detection of early lung cancer.
Excellent. Dr. Daniel, Jenny, you have anything you'd like to add on that?
I just wanted to add, obviously there always has to be discussion about risks and benefits with any sort of testing. If you notice, we're very careful to keep saying low dose CT scan. And that's to emphasize that this is a special protocol for these studies that is trying to reduce the radiation to as little as possible. In some studies, it's the equivalent of about 3 chest x-rays. So it's not the type of radiation that can have long-standing effects. And that's why there is this current recommendation to perform that study.
Encourage while we have these experts here with us. We only have them for a few more minutes. So please, if you have any more questions, try to get those in the chat. I want to ask a question that just popped into my mind. Excuse me. We just got a question from, it looks like Dave is asking, any treatment for emphysema with a pulmonary embolism 5 years ago? I quit smoking when that happened, but I have ongoing breathing episodes. I'm a patient at Morsani, he says. So he wants to know if there's any treatment for emphysema with a pulmonary embolism.
I'll take this question. It's a very challenging question because of the physiology that is affected when you have a blood clot. Hopefully the blood clot is going to be treated and can be resolved. And then the focus is on, is there a way to make the emphysema better besides medical management? We have an excellent lung transplant team here at USF TGH, and they have a separate division that looks at patients with advanced COPD. And even though you may not be quite ready for a transplant, there are other interventions. One of those is something called lung volume reduction surgery that can be done either with a bronchoscope or sometimes surgically. So it's a long-winded answer, no pun intended there, but the long and short of it is need to be evaluated for that type of intervention. It's called lung volume reduction surgery for emphysema. And the best way to do that is to see the experts here at the Transplant Center.
Daniel, well, I want to thank our audience. They are said we're getting some fresh questions in real time here. Here's another one. Who is at for lung cancer other than smokers and people around smokers?
I can take this one. So obviously, like 9 out of 10 cases of lung cancer are related to smoking. So that's the number one risk factor. But there are other risk factors. Secondhand smoking is one of them. Exposure to radiation. For example, if someone received radiation for breast cancer or sarcoma or lymphoma in the past, and they are at increased risk in the future. There are other less likely, for example, genetics. We touched upon that earlier. So sometimes you're born with a genetic defect that increases the risk of lung cancer. There are things like radon exposure, which is not as common, but it was an industrial pollutant in the past. Then sometimes it's like things like supplements occasionally, like beta carotene was studied in smokers to prevent lung cancer, and it seems like it increases the risk of lung cancer. So there are several. Pollution is another one, and actually we're learning about it more as we go. So just the environmental pollution. Obviously, it's kind of difficult to change your environment, but that is one of the risk factors that is being recognized at this time as well.
Fascinating. Thank you, Dr. Ashraf. We do have a few more minutes with these experts, so please keep those questions coming. We've got some more here, so I'm just going to tee them up for you guys. Stage 4 lung cancer patient. The patient was on, and forgive me if I'm mispronouncing this, alectinib, but it was a damaging the liver. It says alectinib treatment did lead to reduction of the primary tumor. Do you have any suggestions for managing symptoms on brigatinib, including pneumonitis, fever, etc.?
Okay, yeah, I can take this one. So lectinib is a pill that you take, and it's usually used in stage 4 lung cancer who have a certain mutation called an ALK mutation. It is a very effective treatment, as this person mentioned, but one of the side effects is it can cause liver damage. Now, usually what we'll do for that is that we will monitor the liver function test every other week for the first 3 months. And if we see any signs of liver damage, we sometimes hold the treatment or reduce the dose. I'm assuming that this patient is now on brigatinib, which is also another 3rd generation ALK inhibitor. And so that is a very effective medication, but it can cause problems such as pneumonitis or fever. So what we do is on the first week that we start brigatinib, we start at half the dose. 1 week later, we increase the dose to a full dose, and that has really reduced the incidence of pneumonitis. Now, some people may still develop pneumonitis after the dose is increased, and you can use steroids. The other side effect is fever. The steroids help with the fever as well, so a short course of steroids can sometimes help. In spite of that, I have seen that some patients still have problems with pneumonitis. In those situations, we keep them at a slightly lower dose of brigatinib. Now, the good thing with ALK-mutated lung cancer is we have a lot of options. More recently, a 3rd drug called lorlatinib was approved, and lorlatinib doesn't have these same side effects such as pneumonitis or fever, and it seems like it's actually more effective than all the others in the past. I will warn you, though, that lorlatinib has a very high tendency or penetration to the brain, which in a way it's a good thing because this type of cancer likes to go to the brain. So it's very effective there, but it can cause problems sometimes like hallucinations. So that might be one of the things to monitor on that. So well, my suggestion would be that try the steroids. If that doesn't work, reduce the dose of brigatinib. If it still causes problems, then either switching to lorlatinib or going back to a lower dose of alectinib. I do have several patients who are on lower dose alectinib, and they do just fine as well. So those are some of the things that you can do.
I would just like to add, it's great to hear all these new treatment options that Dr. Ashraf is mentioning. These terms that are difficult to pronounce, these drugs weren't even here 5-6 years ago. And so it's an exciting time because we anticipate that this is going to increase. And of course, we like to get patients early when they can be cured with surgery alone. But in the majority of patients, that's not the case yet. And so having all of these multiple treatment options and an expert like Dr. Ashraf is fantastic.
Yeah, absolutely. I agree with you. I mean, this has been an explosion. I mean, it's all possible due to all the research going on in lung cancer. And there's another one that I didn't mention, ensartinib, and that's under development, shows very, very good results, and that might be available commercially as well. So those are things to look out for.
It's a fantastic discussion around that. Thank you to our panel. And I do want to let our panelists know, because they can't see the comment section here, but I want to let you all know we're getting some positive feedback from people who are saying, thank you for the information. This is insightful. So really, this people are getting value out of this conversation here today. And I really want to thank all three of you. I've got one more question I want to get to before we let you all go. Who is at risk? We're here. How about this one? Juliana asks, is vaping considered smoking and a concern for developing lung cancer? You guys can rock, paper, scissors.
I can take this one. So vaping does not have the same effect as smoking. However, it does seem that it also increases the risk of lung cancer to some extent. So when you're smoking cigarettes, there are about 300 different carcinogens, which means chemicals that cause people to develop cancer. But when you're vaping, it's not the same number. However, it's not safe either. In the past, it was thought that, oh, maybe you should stop smoking and go to vaping as a way to quit smoking. But now we know that's not correct. And the US Surgeon General also recommends against vaping. So it is almost considered like smoking, not exactly the same, but it is a risk factor. And it has other side effects as well, which I didn't get into.
Yes, there's actually, anytime you start to experiment with new drugs such as vaping, unfortunately, new disease processes can occur. And there is a particular one called vaping-associated lung illness, which is extremely severe, and it is not actually related with chronicity of using vaping. It can happen after just a few doses, and those patients can get very sick, even end up on the ventilator. You only have to see it once to realize that, unfortunately, vaping is not a good solution to quitting smoking.
Well, again, I would like to take this opportunity to thank all three of our panelists today, all very busy people, and to give us your time to have this important conversation and raise awareness again for Lung Cancer Awareness Month. Thank you all. And I know by looking at the comment section that our audience got a lot out of this as well. So Dr. Daniel, Dr. Ashraf, Jenny, thank you so much for your time today.
Thanks for your help and time too, Phil. Yeah.
Thank you for having us.
Thank you.
Listen, it has been a pleasure. I do want to remind our audience, for more information on the TGH Cancer Institute, you can visit our website, which you'll see at the bottom of your screen. You can also call 813 for expert live Q&A session. Have a great rest of your day, everyone. Thanks again.